Our next speaker is one of our own here in-house, Dr. Evan Schwarz. And many of us know us, but there's actually many guests we have here. Evan is an emergency physician. He has boarded in toxicology and actually boarded as well in addiction medicine. And he, within our Division of Emergency Medicine, he has been a major driver of addressing the opioid crisis and how can we as a medical community, how can we as physicians help. He's established an addiction clinic just down, about a block down at the Center for Outpatient Health. He does the inpatient, we actually often have people who present, for inpatient services, someone who has been using intravenous drugs and they get infections on their heart valves, they have endocarditis, they maybe need cardiac surgery, they have ongoing addiction issues in the hospital where they can't stay, they have to leave, because Evan helps with that, and he helps in many other formats. He's also, I think, upcoming president of Missouri College of Emergency Medicine, addiction, the Midwest, there's many different components, also with an addiction chapter in the Midwest, I believe. So, Dr. Evan Schwarz.
All right, well, thank you, Randy, and thanks for everybody that came today. When we first started to organize this, in no way did we think we'd have this many people, and especially thanks to all the elected officials that came out. Honestly, we were hoping to get one of them here, and within like a week of the response, all of them said yes, and it was a fantastic problem to have to try to figure out how to squeeze everybody into a short schedule. So one thing we did want to talk about, we don't have a whole lot of time, but we did want to talk about pain management and addiction, because this is kind of a piece that gets forgotten and kind of glossed over very quickly. And really, when you're talking about pain and you're talking about addiction, these are things that are very intertwined, and we really need to do both of these well if we're going to really tackle this problem and help patients. And so that's why we want to spend a little bit of time talking about this. All right. So the United States didn't always look like this as far as all the opioids and pills that we were used to giving out. So if you go out maybe 30, 40 years ago, physicians were very hesitant to give any opioids because they knew how addictive they were. So if you had very severe trauma, maybe if you had cancer, those were kind of the times when people were prescribing opioids, maybe after surgery, but people were very hesitant to give them out because we knew about all the long-term damage that that had caused. Somewhere in the early 80s, that pendulum kind of started to swing from all the way on one side to the other side. And it started with a lot of people say this one study that we'll kind of take a look at real quick. I know there's a lot of people here that aren't primarily in medicine, so just real quick, when we're talking about studies, we're normally talking about things that are 5, 6, at least 7 pages, have an introduction, methods, results, discussion. This isn't that. This is 11-line letter to the editor. Now, it was published in the New England Journal of Medicine, and it's just kind of talking about a couple physicians' experience in the hospital with opioids. Doesn't really say how they did it, how they defined substance abuse disorders or anything else like that. The problem is this thing became cited and heavily cited, and it became cited as opioids cannot cause addiction if they're prescribed by a doctor and that they're safe. And nowadays when I get an article that I'm looking at, I can easily go to the online, look at the article, look at the reference and see, hey, is this actually what these authors said? If you go back to the 80s, if you were at home reading your journal and this was cited, what you'd have to do is actually walk to a library, go up there, find the article, open it up. So it's really hard to do, and so it's really hard to verify when people cited this saying that you're not going to get addicted, that was actually true. And someone this year went back in the New England Journal of Medicine and looked, and this article's been cited somewhere between 800 and 1,000 times since then. And it wasn't just articles like that, it was articles like this. So this is the chronic use of opioid analgesics in non-malignant pain, report of 38 cases, and this was also a very heavily cited article saying that opioids were very good for pain. What they don't say is about only 37% of the patients actually had adequate pain relief, and then even of those, no one actually had an improvement in functional status, which is really the biggest reason why we start people on medication, is so they can get back to the things in their lives that they really like. One of these authors also was very big in promoting opioids, talking about how it's safe to manage people chronically on opioids, and there may be some people like that, but kind of saying everybody should be like that, and really started going into this how we're having an opioid undertreatment epidemic, and was on multiple boards and on multiple things saying we need to give more and more opioids. And eventually that led to things such as pain is the 5th vital sign, which anybody that's practiced recently knows that that's why everybody, no matter what, gets asked what type of pain you're in, and they put it right next to the other vital signs. So there's heart rate, blood pressure, temperature, and then how much pain you're in. And not surprisingly, all those things led to this. So you can look at this in multiple different ways. I just picked total prescriptions. This is from the CDC in 2012. You can look at actually opioids prescribed in kilograms on that website as well, which is also pretty startling. And if you look at Missouri, we're kind of the striped state. So in 2012, between 82 to 95 prescriptions per 100 people were being handed out. So basically, in 2012, every adult in the state of Missouri should have gotten a prescription for some type of narcotic, meaning if you didn't get a prescription, someone else took your prescription. And if you look, we weren't even the bad states. There's states even worse where it was greater than one, almost 1.5 prescriptions per person in that state. And while that's a huge problem, obviously, the overprescribing of opioids isn't the only issue and not the issue we're here. The issue is it leads to this, and it leads to this huge increase in deaths. So you can see the death rate from opioids climbing from 1999 through 2014. Keep in mind in 1999, that's around when pain became the fifth vital sign. You also had huge opioid campaigns. Things like OxyContin were really being pushed in the mid-90s, being put on the market. And the amount of opioids going up that were being sold and used went up. And you can see the amount of deaths related to opioids. And what we know is if you abuse prescription opioids, you're 40 more times likely to abuse heroin than people that never abuse prescription opioids. And as you can see, eventually the death rates from heroin, the green line at the bottom, started going up. Now, significantly in 2010, that's when fentanyl and fentanyl derivatives were really starting to be added to the heroin supply, and that's why those death rates went up so much then. And so the expected response happened. The pendulum swung completely the other way. We heard all about how bad opioids are, how they're horrible. We heard about all these death rates and overprescribing, and it led to people deciding, well, we hear these things are really bad, we're just not going to prescribe them at all. So you got things like the oxy-free ED, and if you talk to the people that actually created the oxy-free ED, the idea behind that, it wasn't we're just not going to give opioids, it's we're going to prescribe them in a responsible and a judicious manner. However, when you just slap things up like oxy-free ED, the message that you get is we just should never use opioids at all, and that's not exactly the right message. Sometimes they may be indicated. So you look at this gentleman, not to give him a hard time, I'm guessing he tried to skateboard down these steps and didn't quite make it. It looks painful, he probably broke something, and in that patient, you know, it may be appropriate to give opioids. Once again, you need to watch how you do it, but that may be something where it's appropriate to give opioids. And I bring this up because we do have some trainees here, and I'll tell you two stories. So one of the other faculty members was telling me the other day, so in our emergency department, we have several sections, and we have a trauma critical care section, and they had a patient, I believe, who had a very badly broken leg, and so he said, hey, what are you doing for your pain control? And they talked about giving him some Tylenol or ibuprofen, which are fantastic medications. I don't know if I had a new leg fracture, if that would be my first choice, what I'd personally want to receive. So he asked him, well, are you going to give some opioids? And the response back was, well, I didn't think we did that anymore. And that's not the message we want to send out there. In addition, about 2 years ago, I had an elderly lady who had metastatic cancer, and she came into room 14, and she was there because of pain, and she said, you know, my doctor won't prescribe me opioids because they're addictive. Now, unfortunately, we didn't have a PDMP back then, so I couldn't easily check it, and so maybe she fooled me, got me hook, line, and sinker. But, you know, it is concerning if we have someone with, you know, metastatic cancer and we're not willing to treat their pain adequately because we're afraid of all these things. So really, instead of kind of a pendulum response where we just swing back and forth all the way, what we really need is a balanced and thoughtful approach to how we're going to treat these patients with pain. So when we have these patients, it's really important to weigh the risks and benefits for each patient. You know, in emergency medicine, we're not generally taught about taking a history of substance abuse in the family, in their own life, family history. Now, it is important to note that just because someone says they don't have a history of substance abuse and they don't have a family history of addiction or things like that, doesn't mean they're not at risk, but you can at least stratify how at risk someone is. And then there's things like, you know, are non-opioids appropriate, either as monotherapy or adjunct therapies, and we don't always do a good thing giving people tools of, okay, I don't want to give you opioids, but I still want to treat your pain, about things you can do. I will say there's a fantastic program that started to develop in the last couple of years, the Alto Alternatives to Opioid Programs. One of the main emergency medicine societies is pushing this. With that said, you don't actually have to be a member. If you just Google things like that, it can give you a whole slew of opioid alternative pain regimens. And I can tell you just about a month and a half ago, I had a gentleman that came in, was overweight, had some bad pain, and probably 6-7 years ago, the response would have just been to give him some opioids. Instead of that, we gave him aggressive NSAID therapy, ICE, which is something that I almost never see actually used in the emergency department anymore. And then we gave him trigger injections, and we actually slapped on some lidocaine patches. And about 30 minutes after all that, he was actually walking out of the emergency department and feeling better. And we were able to do that without opioids. However, if you're using opioids, and sometimes opioids may be the indicated therapy, it may be the best thing for that patient at that time, there are things we can do. So using the least euphoric opioid, and we do have literature that some opioids are more euphoric than others, start at the lowest dose possible and prescribe for the shortest reasonable duration, and make sure that, the indication that you're prescribing is, the good idea. So, as Representative Rader said, laceration to a hand got a bunch of Lorcet, and it may have been indicated, but it may not have been the best idea. Or, we hear these stories of people going for something and getting 160 tabs of oxycodone or hydrocodone, and maybe they do need some oxycodone or hydrocodone, but maybe they only need a couple days, and then they can be reevaluated and then determined if they need further therapy. Because then the other question is this medicine really helping them? And if opioids really aren't helping the pain, then it may not be the best medication for them. And then also just honest discussions about our limitations, about how much we can improve your pain, and about how we're not going to necessarily take your pain from a 10 to a 0, but our goal is to take your pain from a 10 to maybe a 6 or 5 and make it tolerable and make you functional. And then I don't have it on here, but also on this should be, if we suspect addiction or substance abuse, then we should be referring these individuals for treatment instead of just kind of kicking them out of the ED and saying we're not going to prescribe them opioids.